Okay, good afternoon, everybody, and welcome to this inaugural lecture by Professor Eugene Dempsey. Professor Dempsey is a consultant neonatologist in our Cork University Maternity Hospital and Horgan Chair of Neonatology in the Department of Paediatrics and Child Health here in University College Cork. My name is Helen Welton, and I'm the head of the College of Medicine and Health here in UCC, and it is my very great pleasure to introduce Professor Dempsey to you this afternoon. I would like to offer a particular welcome to Dara and Anne Horgan, whose very generous support has made the creation of this chair in neonatology possible. Jean qualified for UCC in 1995 and trained in the Coombs Women and Children's University Hospital, the National Maternity Hospital in Holles Street, and Our Lady's Hospital in Crumlin, before moving on to McGill University in Montreal, where he completed subspecialty training in neonatology at the Royal Victoria Hospital and the Montreal Children's Hospital, McGill University. He returned to Ireland and worked as a consultant neonatologist in Coombe Women and Infants University Hospital and Our Lady's Hospital for Children in Crumlin. He moved to the Cork University Maternity Hospital on the opening of the new hospital in November 2007. He has a keen interest in clinical research and evidence-based neonatology, and he's a PI in the Infant Centre, which is the Irish Centre for Fetal and Neonatal Translational Research. The Infant Research Centre is a UCC research hub with trans-global affiliations, whose pioneering work focuses entirely on improving health outcomes for women, babies, and young children. Jean is also supervising quite a few ongoing clinical research studies and higher degrees in the area. He's a member of a number of national committees, including the Faculty of Paediatrics and Royal College Research Ethics Committee. He currently lectures both in the College of Physicians and the College of Surgeons. I'm really delighted to say that earlier this year, following an international search, Jean was appointed to the Horgan Chair in Neonatology at UCC. The support for this chair underpins Jean's extremely important and internationally acclaimed research in neonatology, research which benefits some of the most vulnerable in our population, improving survival rates and quality of life for small babies and their wider families. So what about Jean the person? Well, Jean is originally from Youghal and is the son of the late Michael and Breda Dempsey, who we remember today. He started out, as many of us did, with the nuns. His were in Presentation Convent in Youghal before he graduated at the age of 6, I suppose, to the Christian Brothers primary and secondary schools. He was a child with a very keen interest in sports and played both GAA and rugby. You can imagine that might have been difficult from time to time. He was clearly as fearless as an athlete as he is as a professional, because he told me that over the years, he broke his nose, not once, but twice. He broke both clavicles, cheekbone, multiple fingers and vertebra, but he's still to the good today. His interests in the body and its physiology drew him towards medicine, and he started in UCC in 1989. He met his wife, Siobhan O'Keefe, in A&E one night as they were both looking after a little boy who had suffered a seizure. Jean wasn't sure how the boy is doing today, but he certainly kept in touch with Siobhan, and they got married in 2001 and have 3 children now, Sadie, Robin and Miles. Jean's training then brought him to Dublin and then on to Montreal, and he attributes his move to the Robert Usher Fellowship in Montreal in McGill to Professor Tony Ryan in neonatology. And Tony, as he influenced many people, influenced Jean and made a huge impression on his career. So he moved back to Dublin after 3 years in Montreal, and once the new CUMH hospital was built, we were very fortunate to recruit him back to Cork. So I'm delighted to introduce Jean to you, and I will now hand over to Jean for his inaugural lecture. Thank you, Jean.
Thank you very much, Professor Welton, for the lovely introduction. I'd like to begin by saying that I'm very fortunate to be associated or be part of the 4 institutions that I've listed at the footer of this slide. First and foremost, as Helen mentioned, I am a neonatologist. I work in a busy maternity hospital with over 7,500 deliveries annually. We have somewhere in the region of 1,300 admissions annually to our unit, 400 preterm infants less than 35 weeks, and 120 born very preterm, less than 32 weeks. I'm also part of the infant research center, and this center is co-located in both the maternity and the CUH. This maternity, this amalgamation of the research and clinical side of things has really led to significant advances in clinical research within our setting. And I think that has impacted on the care that we deliver to our infants. And over the next 30 minutes or so, I want to share with you some of my own experiences. The particular group of babies I'm talking to you about today are babies who are born extremely preterm. And here, just to orientate you, this is a porthole through which one places one's hand when one is examining a baby of this size. And you could quite conceivably hold this baby in the palm of your hand. And here on your left, you see a fetus in the in utero environment, and on your right, a baby at 24 weeks in our neonatal intensive care unit. Normality resides on the left, abnormality resides on the right. And it's really important to take these into consideration when we're dealing with babies at this gestational age. Here is a schematic of what's happening to the brain over these weeks. Lots of things happening that should really be happening within the in utero environment, and instead they're happening in the incubator, if you will. These processes such as neuronal migration, synapse formation, programmed apoptosis, all of them should be happening in utero, and instead they're happening in the unit. And here you see a representation of a full-term brain, and here a preterm brain. And you can see just how smooth it is. And these are the sort of things that influence brain development at this time. Low or high oxygen, lower or high blood flow, impaired respiratory support, infection, inflammation, environmental stimuli such as noise, stress in the form of pain, impaired nutrition, all of them contributing to the risk of brain injury. And here, what we want is actually to allow that brain to mature in the ex utero environment and avoid brain injury. And the sort of injury I'm alluding to are injuries that occur secondary to hemorrhage into the ventricles here, or out into the parenchyma of the brain, and more subtle injury in terms of white matter injury, or more obvious white matter injury referred to here as cystic periventricular leukomalacia. So what I'd like to do is take you through the continuum of care that we provide to preterm infants from the delivery room through to the neonatal intensive care unit. And along the way, I want to highlight a number of, I suppose, the studies that we've done to try and address some of the issues around looking after and protecting the preterm brain at this gestational age. And first and foremost, the most important thing initially is how we manage the umbilical cord when a baby is delivered. And by that, I mean, here you have a video, which I'll play shortly, of a preterm infant in around 28 weeks delivered. And here you can see the cord, baby is still attached to the cord. We have the obstetricians delivering the baby. And at the top of the bed here, we have a neonatologist who's available to provide respiratory support if so required. And I'll take you through the video now. If you watch what happens, you'll see down the bottom corner of the image, you'll see a pair of hands place a face mask over the baby to provide respiratory support if indeed required. There are many different ways of managing the cord when the baby is delivered. You can milk the cord, which is a process of catching the cord and stripping it towards the baby. So if you will, actively transfusing blood into the baby, or as you've just witnessed here, the process of delayed cord clamping, where you allow passive transfer of blood from mom to the baby. Previously, years back, immediate cord clamping was practiced, and we now know that placental transfusion in one form or the other is a better option to immediate cord clamping. And we've done some work within our own institution, and this is work from a previous fellow of ours, Dr. Finn, who I'm delighted to say is a cardiologist over in the pediatric ward now and visits our unit very frequently, providing support to us within the neonatal unit. But this particular study was looking at the role of ventilation, providing ventilation with delayed cord clamping in the delivery room. And what I'd like to highlight from here as well is actually the fact that we did look at measures of brain health, if you will, in this population of infants. So we looked at measures of EEG activity and cerebral oxygenation at various time points within the first 24 hours of life. And this really was a lead-in to our multi-center site international study led from San Diego. And this was comparing two standard of care practices, I guess, at the time, umbilical cord milking and delayed cord clamping. And what I'd like to highlight to you in this graphic is the outcome for our most immature babies. So those babies delivered at 23 weeks to 27 weeks. And here you see, looking at the group who've had umbilical cord milking compared to delayed umbilical cord clamping, you see a significantly higher incidence of severe intraventricular hemorrhage, so grade 3 or grade 4 hemorrhage in the group who've had umbilical cord milking performed. So it's important to note that this practice now, or this trial, is translated into our own service, where for babies delivered at the extreme of viability between 23 and 27 weeks, they are all in receipt of delayed cord clamping. And this provides us with some of the physiological basis behind the changes that occur. And in the context of this trial, there was a sub-study, which we were part of, that measured continuously respiratory support provided to the infant, brain oxygenation monitoring provided to the infant over the first 15 minutes of life. And what I'd like to highlight here is that for the babies in receipt of umbilical cord milking, they had a better overall peripheral oxygen saturation value with milking, and actually had a lower mean airway pressure required compared to who had delayed cord clamping. So initially you would think, well, maybe there's a better, if you will, adaptation following umbilical cord milking. So with facilitation of lung expansion and improved pulmonary blood flow, optimizing what one would believe to be cerebral blood flow. But in actual fact, the concern arises in relation to increases in cerebral blood flow that can occur with the milking process, resulting in severe injury. So we are also part of a larger international collaboration addressing this topic as well, called ICOMP. And in this particular review group, we are looking at individual patient data and trying to determine optimal management strategies for the various different gestational ages. And that is ongoing at the moment, led from Sydney, and we hope to have some results within the next 6 to 9 months from this very complex review process. So I've alluded to the first minute or so of life, but I think that the next important element to address is how we provide support to preterm infants at this gestational age in those first minutes of life. And here you'll see, I'm going to play a video shortly of a preterm infant, about 25 weeks gestation being delivered. And the view you're getting is from the provider who's standing at the head of the bed, looking after the baby's respiratory status. You have other personnel involved wearing these particular glasses recording the process as a quality improvement initiative to see if we can optimize our management of babies in the delivery suite. And so here you see little baby dried gently, elevated, being placed down on the bed. An oxygen saturation probe, that's the little orange light that's been applied to the right hand. Electrodes being placed on the baby to obtain ECG, and the face mask being applied here to provide respiratory support. And this is critical. This is a really important element of the transition process. And we know that from a lot of animal work that's been done. A lot of this work done in Monash in Australia, and we've been collaborating with this group over the last number of years also. And here, just to talk you through the process. So when we say high VT, what we mean is high volumes of air or oxygen being delivered to the lung. So we set our devices at a certain pressure to minimize injury to the lung. But here, the process of high tidal volumes can impact on the pulmonary alveoli, causing injury to the alveoli. Also, the high volumes can cause an impairment of blood flow to the lungs and from the lungs as well. So you have this dual hit, if you will, from altered, or if you will, high tidal volumes being administered. So an impact on the pulmonary, on the lung itself, sorry, and an impact on the blood flow to the lung, from the lung, and to and from the heart also, which I think is an important point to remember as well. So it's really critical that you're familiar with the devices you use to provide mechanical respiratory support in the first minutes of life. And this is work that one of our previous fellows, Colin Hawkes, did. And Colin's now an endocrinologist in the pediatric side, and he comes and visits us as well to deal with endocrine problems that may occur in the newborn population. But this was some seminal work from years back, looking at the NeoPuff T-piece resuscitator, which is the standard device that one would use to provide a consistent respiratory support. The problem with it, of course, is that it's flow dependent. And in the absence of what's called a flow restrictor, you can have very significant elevations in the pressures you deliver, and ultimately causing injury to the lung and, as a consequence, injury to the brain. So highlighting this problem was critical. A couple of years later, strangely enough, his brother, Gavin, arrived on the scene. And Gavin came to us from the social science. He had a degree in social sciences, but actually came to do a master's with us and actually stayed with us for 3 years to conduct a PhD on this whole area of manual ventilation in the preterm infant. And one thing that we noted, this was a number of years back, was the lack of interest really on carbon dioxide detection as a mode of directing respiratory support. And so we set out on exploring this topic, a systematic review of its utilization. And in very simple terms, if you have a face mask in situ over a baby, and that baby has what we call obstructed breaths. So the air, you may be attempting to push it in, it's not coming back out. When air doesn't come back out, the carbon dioxide that you'd expect to be present isn't present. And so you won't see a carbon dioxide either trace or colorimeter change. And as such, then you're more prone to increasing the pressure to try and overcome whatever obstruction may or may not be present. And in doing so, you're more likely then to inadvertently cause injury to the lung, the blood flow to and from the lung, the blood flow out of the heart, and ultimately the blood flow to the brain. So we spent some time looking at this within our own delivery suite. And here's an example of what I'm talking about. This is advanced monitoring for preterm infants in the delivery suite. And to orientate you, again, this is a person at the head of the bed providing respiratory support. You can see what's called a two-handed technique here, holding the face mask in situ. You have a little line coming out here. This is detecting the exhaled carbon dioxide. This is the T-piece resuscitator I spoke to you about. And this is a baby with ECG electrodes in situ and a bag over the baby. This is a very cost-effective device for preventing hypothermia. And low temperature in babies at this gestational age is associated with increased mortality. So all our babies are placed in bags such as this to maintain their temperature over the first 10 to 15 minutes of life before they're transferred to their new home in the neonatal intensive care unit in the incubator. So what I want to show you here is the sort of monitoring that you can have available to you in the delivery suite. And bear in mind, the majority of delivery suites do not have this sort of monitoring performed. It would be hard for clinicians to understand this, but pulse oximetry, the standard we use, so measuring oxygen levels, pulse oximetry only became standard within the ILCOR, or if you will, the resuscitation guidelines from 2010 onwards. And so let me give you an insight into the sort of monitoring that happens with our own institution. And here you see the baby's vitals that are visible to you. So this is objectifying the assessment of the baby. And here we have the heart rate displayed in real time, the saturations displayed in real time, the baby's breathing pattern displayed in real time. And here, this white line, this is the carbon dioxide being exhaled each time. And here you have a quantification of the measure. And we're not asking people per se to intervene based on this value, but to actually obtain the trace, which will allow you to be reassured that you've got a patent airway. And if you do need to increase support, you do so in the knowledge that you're not going to inadvertently administer excessive tidal volumes. And Gavin, we conducted an RCT in the delivery suite comparing this sort of monitoring to this sort of monitoring, but actually with a qualitative device, so a qualitative carbon dioxide device, which is easier to use. And what we found was that comparing both devices, we had a similar outcome in terms of the number of babies who ended up requiring intubation between both groups. So now within our within our delivery suite, end-tidal CO2 monitoring is standard either with the qualitative or the quantitative device. So this is an important element of care around respiratory support. Oxygen, I think we could have a separate discussion on oxygen in the first minutes of life, because in 2021, we still are uncertain as to what the optimal oxygen to be administered to preterm infants is. We're also uncertain of the target ranges we should be looking to achieve, and how do we titrate babies if their oxygen levels are on the lower side. And also, I think we are a long way off, but I think in time we will have automated oxygen delivery systems available to us within both the neonatal intensive care unit and the delivery suite. So what about turning that question on its head? Well, these are reference ranges that expert groups have suggested. And what's obvious here is that the more immature you are, the greater the initial amount of oxygen that is being suggested should be administered. This target range of 80% is important, bearing in mind that all of us are walking around with saturations in the high 90s, the vast majority of us. These are the optimal ranges that are being suggested for these particular small babies. We are trying to avoid the impact of hyperoxia and I suppose too much oxygen causing injury to the lung, the heart, the brain, etc. And so turning the question on its head, we decided a number of years back that we would actually try and look at brain oxygenation monitoring. The brain, I guess, is the critical organ in a sense, and we're currently measuring oxygen levels in the right hand, which I guess is a good reflection in a sense of brain oxygen delivery. But here, this is work done by a previous fellow of ours who now is a member of staff within our department, Dr. Kanosi, and that looked at the role of brain oxygenation monitoring over the first minutes of life. And here you'll see just how easy it is to apply. And if you watch the top of the baby's head, you'll see the application of the oximeter, and it goes on within seconds. And it's on within seconds, and we have a value within seconds. The question is interpreting that value and interacting on that value. And so for this particular study that Maloki performed, we actually performed an observational study where we just gathered this data and looked at it based on whether babies received more than the 30% we started off with, or indeed whether they stayed at the 30% and were able to wean down on the oxygen that they were in receipt of. And without making things too complicated, these are the saturations of the babies. These are the heart rates of the babies. And yes, for the clinicians in the audience and non-clinicians, these are very low values. These are values 50 to 60 to 70%. But that is transition. That is adaptation. That is what's happening for the preterm infant over those first minutes of life. And here on column C is what we call the RSO2 value. And these are the brain oxygenation values obtained from these groups of infants. And actually our hypothesis was, we were concerned that the higher amount being administered to preterm infants in those first minutes of life may in fact be causing cerebral hyperoxia. So too much oxygen being delivered to the brain. And actually we found the opposite. And here it is represented statistically with what we call a normalized area less than 55%. So this is less than 55% being determined as a quantification of cerebral hypoxia, or low blood oxygen levels in the brain. And here we see the group who required more oxygen actually had more cerebral hypoxia. And that goes back to the slide I showed you here, where we have higher amounts being administered to more immature babies. And in actual fact, maybe we need to be starting off at higher values and titrating up or down based on those. And that's work that is ongoing at present in a number of trials across the world. And we were part of this trial now called the COSCOT study, which is a trial looking at the addition of brain oxygenation monitoring to our standard monitoring in the delivery room. And this was the pilot data from Austria. And I'm happy to report that the trial itself, for which we were a significant partner in, has just finished, has enrolled over 600 babies across Europe. And we hope to report sometime in Q3 of next year. So that's giving you some insight into the umbilical cord management, into our ventilatory support, into the role of oxygen and how we optimize oxygen delivery. But I couldn't leave the delivery room without talking about education and training programs. And this is work that I had the privilege of completing with three colleagues, Tony Ryan, Keith Barrington, and Pammy Mohan from Texas. But focusing initially on the study itself, this was a systematic review of training programs, standardized formal resuscitation training programs from across the world, albeit the vast majority of them from the developing world. The majority of trials within the developed world were more focused on aspects of skills acquisition, skills retention. In the developing world, the focus of the trials was on mortality. And what's really, really informative from this work, and this took a number of years, somewhere in the region of 5 years in total to get this systematic review together. This review showed that for every 227 resuscitations attended by a person skilled in newborn resuscitation, or who has been trained in one of these formalized resuscitation training programs, one life is saved. And that's a staggering figure. And something I think all of us need to be conscious of, certainly in the developed world, when we think of the trials and tribulations that happen in the developing world. And Helen alluded to Tony in the introduction. And Tony, this is a picture of the Ernville. I'm sure you'll be familiar with it. Tony was central to the development of neonatology, following on from Professor Cusson in Cork in the 90s, and certainly I think inspired me to follow a career in newborn medicine. And also, I think an important teaching point from Tony, and Tony is great for teaching points, was the whole aspect of mentorship. And I've certainly learned an awful lot from Tony on mentorship and its importance for our colleagues and our junior colleagues. And also I need to mention Keith, Professor Barrington, who was and remains a very good friend and mentor. And Keith, this is a picture of the Royal Victoria Hospital in Montreal, where I spent 3 years. Keith taught me something really, really important, and that is challenging dogma. And there's so much dogma in everything, I guess, but in newborn medicine, so many purported approaches that are based on, when you dig down into it, based on very little evidence to support their use. So that's something I continue to try and push on and highlight to our junior trainees, to our medical students. Don't be afraid to ask why, and challenge approaches that are there. And so I'm forever grateful to both Keith and Tony for their mentorship, for their career advice over the years and over the coming years as well, I guess. And I couldn't leave the delivery room without also highlighting some work that we've begun with Fred Adam from the business school in the university, focusing on human factors and around how we as individuals contextualize individual cases, optimize management, and really, I suppose what we're pushing towards now is the whole area of artificial intelligence, augmented intelligence in optimizing the delivery room management of preterm infants. So an exciting project over the next number of years, and hopefully in years to come, we'll be able to present this critically important work. So I spent the last while talking to you about the delivery room. I'd like to spend the next while talking to you about the neonatal intensive care unit, where all of these factors, all of them, come into play. I don't have time, sadly, to address all of these, but I think what I'd like to focus on are some key aspects around brain oxygenation monitoring in the first days of life, the importance of cardiovascular adaptation, bearing in mind that the extreme preterm infant is really ill-equipped to deal with extrauterine existence. When you think of the preterm myocardium, the heart, it's a very small structure, but it's also developmentally very immature. It doesn't have the normal contractile elements that our hearts have. It has a lot more non-fibrous tissue, and so it doesn't contract as well. I'll highlight the importance of sleep, not for me or for my colleagues, but for babies and the importance of it in terms of development, and also the importance of understanding the microbiome of our preterm infants. So this was seminal work from a number of years ago from what's called the Safe Boost collaboration. And myself and 4 others are key members of this group across Europe. And this original study was a pilot study, and it randomized over 166 babies to 2 approaches. One approach was having one of the monitors visible to you, measuring brain oxygenation levels, setting certain limits and intervening based on those. And the other was having the monitor in situ, the values not available or visible to the clinician, and standard of care was provided to those babies. And what's interesting here, these are the results of the study. I mentioned 166 babies in total. And this group here represents the group where the NIRS was visible to the clinician. And these are the NIRS, the oxygenation values not being visible or blinded. Our primary outcome was a measure of what we call the burden of hypoxia, so time spent below 55%, or time spent above 85% for the particular monitors that we were using. And what's interesting is, and wouldn't surprise anybody in the audience, is that if you have the device visible and you're interacting with it, you're more likely probably to be within range. But what was interesting was the vast majority of the time was spent outside the range. So they were more likely to have cerebral hypoxia as opposed to hyperoxia. And there was a signal around mortality that where the device was visible and clinicians were acting upon it, mortality was different in that group compared to the blinded group. So over the last 2 years, SafeBoost 3 has been enrolling, and Cork has been the national lead for this study in Ireland. And I'm happy to report that our colleagues in the 3 maternities in Dublin are all part of this. One of the first studies, I think, nationally to include the 4 neonatal large tertiary neonatal services. And this study is due to complete in the next probably 4 weeks. We've enrolled a staggering 1,550 babies so far across Europe, the States, and China. And this really, we hope, will provide us with insight into the potential benefit of near-infrared monitoring. So one of the first device trials, if you will, in the newborn population. A thing that I'm particularly interested in is blood pressure. And I alluded to Keith talking about dogma. So when I started training, hemodynamic instability was measured by blood pressure. There was little focus on blood flow, mainly because you can't reliably measure it, but the focus is on blood pressure because you can easily measure it at the bedside, and you can come up with rules to treat when it's below a value or not below that value. And low blood pressure has been associated with short and long-term adverse outcomes. And many babies at this gestation age category, babies less than 28 weeks, continue to receive treatment to support their blood pressure in the belief that it improves end organ blood flow, and as a result of that, improves outcome. But treatment of low blood pressure has been associated with adverse outcome. And we set out to challenge that dogma by conducting a trial, basically where you would randomize babies to receive intervention based on a blood pressure value. And so in this particular study, 58 babies were enrolled, half of them to what we deemed a standard approach, which was giving a drug to increase their blood pressure, and the other half received a placebo and were, in essence, in the observational arm. So questioning whether you should intervene based on a particular value or not. And what's interesting here, just to point out to clinicians in the audience and lay people, I guess, in the audience as well, we're talking about very low blood pressure values here. We're talking about blood pressure values in of the order of 21 and 22 milliliters of mercury, but babies who are very well perfused with normal lactic acid values. And here what we found was that if you were enrolled in the observational arm, 2/3 of babies went on to receive treatment. And of that 2/3, about a half actually received an inotrope. So half the group did not receive a blood pressure support agent. And this is the blood pressure dynamics of the groupings overall. And when I say placebo, this is the arm, the placebo and no second line intervention. This is the arm that received nothing. So they essentially were observed, and you see their blood pressure spontaneously rise over those first hours of life. So I think that the bottom line is, if we can better objectify this group, because this group here in this column to your left, this group had the best outcome. So we need to look at better ways of objectifying our assessment of babies with low blood pressure. And there are many ways of doing this. And echocardiography is one of the most used tools now in terms of assessing cardiovascular instability. There are lots of other bedside tools available to us, and many of these have come through work within our own intensive care unit. One thing I'd like to point out, I guess, and this is an important point for medical students as well that come through our service, this is work that was done by Aisling Smith when she was a medical student within our department. And again, we went questioning dogma. Why are people treating patent ductus arteriosus? Patent ductus arteriosus is a communication that's really important in the womb. It directs blood flow away from the lungs. And when you're born at term, this communication closes. But when you're born preterm, it remains open. And on the right of the slide, you'll see the patent ductus arteriosus here. That's the red jet that's, if you will, pumping blood back into the pulmonary circulation. So you end up getting over circulation of the pulmonary circulation. And ultimately, there are potential risks related to pulmonary bleeding and ultimately bleeding into the brain. So it really is important to go back and ask, what is a significant ductus? And we did this work with Aisling, highlighting some important echo parameters that might reflect the significance of a ductus. So for any medical students that may be listening, please don't hesitate to get engaged with us, and we'll take you under our wing and get you doing some projects within the neonatal intensive care unit. This is work I wanted to highlight as well, mainly out of Cork, but in collaboration with colleagues from Leuven as part of the blood pressure trial that I spoke to you about previously. This is really seminal work looking at the impact or potential impact of low blood pressure on brain oxygenation values. And for those of you who are focusing and number focused, you'll see here the value is less than 63%, and I'd mentioned 55% previously. Well, this is with a different probe. This is with a neonatal probe as opposed to a pediatric probe. And what I want to highlight is for the normotensive groups, so those babies who do not have low blood pressure, and you can see that here over the first days of life, their blood pressure is significantly different to those babies who are hypotensive. There's no difference in their global cerebral oxygenation values. That's what the RSO2 value refers to. But when we look at markers of cerebral hypoxia, so less than 63%, we see babies who are hypotensive spend a greater percentage of their time with a NIRS or cerebral oxygenation value less than 63%, suggesting that low blood pressure is associated with low brain oxygenation. And again, we need to better objectify these babies before we begin initiating treatment. I'm really thankful to the work that John O'Toole does for us here as part of the Infant Research Centre. This is really interesting work in collaboration with colleagues from Antwerp, looking at one physiological parameter that's obtained from the bedside in every baby. It's called the pulsatility index. It's measured from the saturation probe. It's not an additional device. It's a measure that's available for every baby in the unit. And in very simple terms, the pulsatility index reflects the strength of the pulse. And here you see the raw signal, and you see it decomposed into different signals based on the frequency of these waveforms. So these are slow and fast oscillations. And what I'd like to highlight here for you is babies who have a good outcome, and good outcome in this instance was absence of brain injury. And in this particular study, babies who had higher pulsatility index values had a better outcome to those lower on the trend component of the signal. And when we looked at variability around the signal, again, babies who had a normal outcome tended to have higher values of what's called the D-trend component of the signal, suggesting that this value is a really potentially important bedside tool that needs and warrants further exploration. I couldn't finish a talk without highlighting the fantastic work that Geraldine Boylan has done in terms of neuromonitoring within our neonatal intensive care unit. And this again is data looking at the relationship between blood pressure and brain activity measured with EEG. And in this particular study, we correlated the relationship between these two signals, two physiological signals, and illness severity scores. This is complicated. You need a lot of clever people, and thankfully we have a lot of clever people who assist us with analyzing this data. And these interaction models relate to how do you relate two signals? So measures such as coherence, correlation, and in this particular study, a term called adjusted mutual information. And in simple terms, the higher the AMI value, the greater the relationship between these signals. And so you can see babies who are sicker, as adjudicated by a very elevated Cribs score, tend to have lower AMI values, suggesting a disconnect between blood pressure and EEG when the illness severity is higher. Again, giving us insight into the potential role of brain oxygenation monitoring, EEG monitoring in these small infants, ultimately trying to optimize their management and ultimately trying to reduce brain injury. An important aspect that is probably not considered enough is that of sleep. And Marianne Ryan was one of our nurses within the unit, and Marianne has spent the last 3 years doing a PhD on this whole area. And we're very much looking forward to the results of this over the next 6 months or so. But it's important to highlight that the environment is really important. And suboptimal structural physiology and neuronal growth and connectivity and synapse plasticity and that can be influenced by what's going on in the environment. So it's really, really important that we're aware of that and embrace sleep for these preterm infants. And here you see the importance of EEG in terms of determining sleep cycling within preterm infants. And I say that, and I'd say around the environment because NIDCAP is such an important element of what happens within our unit. NIDCAP is Neonatal Individualized Developmental Care Assessment Programs. And these are some of the heroes, I guess, who have been running this, the nursing and allied healthcare professionals, within our neonatal service. And so when you come into the unit, you will often find it's a very quiet environment. It's a dim environment, as in the light is down. And really we're there to foster, if you will, brain growth in these preterm infants. Highlighting it is really important and delivering upon it is critical. Something for the future, this is work that Urate Panavien, one of our current research fellows, is doing in conjunction with Tyndall, looking at the potential role of measuring lung oxygenation non-invasively and ultimately transferring that technology down to our smallest babies. And happily, through significant collaboration between these organizations, this study is up and going in healthy term babies in the maternity service at present. And it's impossible to talk about research within the context of UCC without alluding to the APC. And this, I guess, is such an underexplored area within the newborn world. We are gaining information about it have been over the last number of years through the work of Paul Ross and Catherine Staunton and my predecessor, Tony. But the importance of it, I think, is it's not understood at present. And so we are, and have been for the last number of months, looking at this in the preterm population. And David Healy is currently conducting a prospective longitudinal study looking at the gut-brain axis in this preterm population, having enrolled somewhere in the region now of 35 to 40 babies over the last number of months. And it's nice to see Dave looking at the implications of breast milk, because Dave, as a medical student, when he was with us, looked at the importance of early expression of breast milk for this preterm population and the implication of early expression leading to a shortened length of stay for our preterm population. So the circle is almost being completed with Dave's current work in this area. And finally, to highlight some of the preclinical work that's going on in the background, and this is in collaboration with the physiology department under the stewardship of Ken and Fiona. And this is looking at, if you will, a trilogy of stressors. So extreme preterm birth, dysregulation of oxygen management, and also the impact of infection, in this case in a preclinical rat model, and looking at the implications of these particular insults to the preterm brain. And finally, again, looking at oxygen dysregulation, this is work with Minu from the physiology department, looking at the potential role of machine learning in interpretation of cerebral oxygenation values in relation to peripheral saturation values as well, and looking at the frequency of these desaturations, and are there ways of identifying them in advance and ultimately avoiding these potential drops that may have an impact on the preterm brain. So over the last 40 minutes or so, I hope I've conveyed to you the complexity of dealing with extreme preterm infants within the context of our own unit and nationally and internationally, highlighting the drive towards more neurocentric care, so focusing more on the brain, but I think importantly, highlighting the multidisciplinary nature of everything that goes on within our unit, and also highlighting the importance of the various institutes, departments within the college, and the important role that they have to play within the delivery of newborn care within our service. And also, I hope I've highlighted the international connectivity that we have within Cork University Maternity Hospital and within Infant here based at Cork. The critical element of all of this, and this is the point I want to finish on, is the importance of research active centres. We know that research active centres have better clinical outcomes, and that's what we're striving for, better clinical outcomes in our preterm population. I've lots of thank yous to the funding agencies who supported all the work we've done over the years. Professor Welton mentioned the Horgans, and we're forever indebted to the support they've shown to us in the Infant Centre over the last number of years. I want to thank all the researchers within the Infant Centre, in particular Professor Boylan for leading the centre over the last number of years. To my colleagues, who I'm forever indebted, they're a great bunch of friends, and also to our amazing nursing staff who and allied healthcare professionals who go above and beyond in caring for the infants within our centre. And you know, dads need a helping hand as well, as you can see here from the picture. And I want to thank my own family for everything they've done for me over the years, and for the amazing support that they've shown. And I wanted to finish with this slide. This is a very important slide. Here is a list of all of the studies that have happened within our unit over the last 10 years or so. And they couldn't happen without the support of the 4 organizations I mentioned at the beginning. So it's really important to acknowledge the coordinated work from the Women and Infants Directorate, from the university, from the hospital itself, and from the Infant Research Centre. And I promise I'm going to finish now. Behind every single acronym that's used here are families and babies who have consented to being involved within our unit. And to the thousands of those over the years, we're forever eternally grateful. Thank you.
Thank you, Jean. That was absolutely wonderful and a great opportunity for us all to hear about some of the extensive work that's happening in the maternity hospital, much of which is under your guidance. And thank you for your intellectual curiosity. It's clearly deep within you, but your intellectual curiosity draws clever people and clever scientists to work with you. And I think it's particularly impressive how yourself and the centre draw from the many fantastic disciplines and strong research centres and institutes around the university. And we get a team approach and a multidisciplinary approach, and we apply the best science from the rest of the university to what's happening at Infant and at the maternity hospital. So thank you for that. You're a wonderful team player and a team leader, and you really and truly bridge science and clinical practice. I'm going to open for some questions now. The members of the audience may put up your hand. I have sight of, you can do that with the emojis at the bottom of your screen. If you hover over the bottom of your screen, you'll see reactions. And I have a first hand up from Paula O'Leary.
Sorry, Jean, I wasn't able to be here at the very beginning, but I have tuned in. I don't have my red gown on today, but I just wanted to say on behalf of everybody at the school, I mirror everything that Helen has said. You've been a fantastic colleague, a fantastic researcher, and a fantastic mentor. And I wish you many happy years into the future. And I'm sure you'll have very productive years, both in undertaking these wonderful research projects with really meaningful outcomes for babies and their families. But I also know that you'll be a fantastic colleague for those that work with you into the future. Good luck and well done on everything you've done today. Thank you, Jean.
Thanks, Paula.
Many thanks, Paula. And a comment from Catherine Neville, who says that it was such an inspiring lecture, and if it were a live lecture, there would be rapturous applause, but you can take the applause as given. Any other hands up there? Jean, I suppose if I were to ask you, because we have a couple of minutes left, what's big on your wish list for what's next? What would be the one thing that you would wish for?
It's a great question, Helen. There's so many areas that we have not explored properly yet, that we will continue to do so over the years. Without being flippant, a lot of this work comes down to, and you mentioned it, the significant input from personnel within the research center, within infant, in the hospital setting. And to run a research center such as ours, funding is a big element of that. So I think, we continue to push on. Grantsmanship is critical to what we do. Yeah. But I think, the support that the Horgans have shown to us within the center has been a game changer. It really has. And really, I guess, over the next number of years, I think maintaining and holding on to the fantastic people that we have within the center is my key goal. Without them, all of this doesn't happen.
Yeah, thank you. Jean, we have another question now from Patricia Hughes.
No, sorry, Helen, I wasn't asking a question, sorry.
Okay. All right, then, I guess it's 1 minute to 2, Jean, so it remains for me to thank you and thank everybody. We had a really great attendance. We've 80 participants, and delighted to see everybody here, and I can see the representation is from a wide group, both inside and outside the university. So delighted to see so many people benefit from your presentation and your experience, Jean. So thank you very much, and thanks everybody for tuning in.
Thank you, Helen. Thank you, Paula. Thanks everyone for listening.
Thank you.